1 minute to go.
Sir, we have to give another 2 minutes. At least now people are joining.
As you wish.
Arun, should I share the screen? Tell me when I need to go, huh? I'm just sharing the screen. Is it visible?
Yes, sir.
Yes.
Just hint me where I need to go. I think it is another 30 seconds, right?
Yes, sir.
So we can start.
Sure. Good evening, ladies and gentlemen. Welcome to an exciting web series titled Secrets of Neurology. Secrets of Neurology has clinical pearls coupled with recent therapeutic advances. And please block your calendar. It will take place in the year 202021 on the last Friday of every month. Ladies and gentlemen, the Secrets of Neurology is completely a brainchild of two eminent experts from the country, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan, ably supported by his team. Gentlemen, this would be an exciting time of another 1.5 hours. An honor and privilege to introduce Dr. Sudhir Shah, although he needs no introduction, Professor and Head of Department, NHL Municipal Medical College and Sardar Vallabhbhai Patel Institute, Ahmedabad. And Dr. Sudhir Shah is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Author of 6 books on neurology, public education, and several publications in national and international journals. Because of excellent contribution ranging into last 3 decades to nation building, society, and fraternity and people and patients at large, Dr. Sudhir Shah has also been conferred many awards and accolades, just to name a few. Padam Shri, Dr. B.C. Roy Award, FIAN Award, recipient of UN Award, Global Visionary Award. Dr. Sudhir Shah's interest is into stroke, neurodegenerative disorder, and epilepsy. Also an honor and privilege to introduce the second program director for this excellent neurology web series, Dr. Lakshmi Narasimhan Ranganathan. Sir is Director and Professor, Institute of Neurology, Madras Medical College, Chennai. Many awards and achievements to Dr. Lakshmi Narasimhan credit, but just to mention a few for paucity of time, Paltusi Award from AN, Best Teacher Award, Best Paper Award, Global Elsevier Atlas Award. He has been an excellent contributor for various neuroscience classes and teachings nationally and internationally, and has been successfully organizing, just to mention, 7 consecutive clinical neurological science progress for All India DM postgraduate SHINE specialized highly intensive neuro education. Gentlemen, the third and a very important contributor, site coordinator for this web series would be Dr. Ravi, Assistant Professor, Institute of Neurology at prestigious Madras Medical College. His areas of interest is epilepsy and headache. Without much ado, may I invite Professor Saab to take it forward from here.
Sir, you are on mute. Sir, you have to open the mic.
Yes, hello.
Yes, sir.
Very good evening to all of you. Respect to my seniors and love to my colleagues. You're all most welcome to this first episode of this unique monthly webinar series scheduled on last Friday of every month, as Dr. Manoj said. It will take place on every month, last Friday, 8 p.m. onwards. Although this is meant apparently for the education of postgraduate students of DM and DNB neurology, I am sure it will turn out to be useful for one and all, especially the junior practicing neurologists as well as even the seniors. The design of webinar is unique. Dr. Lakshmi, Narsim, and myself have designed this Power Pack webinar very meticulously to incorporate clinical pulse, localization part, anatomical localization, pertinent high-yielding questions related to case, as well as review of literature, mostly focusing on the therapeutics. The pattern will be the same almost in each webinar every month. The first 10 minutes, there will be a case presentation in a very crisp manner over 10 minutes by the third year resident. Then there will be first moderator who would discuss the anatomical localization in 15 minutes. The second moderator will then discuss the high yielding questions or important pulse on that particular case. That will be also another 15 minutes. Then the third teaching faculty will discuss about the recent advances focusing on therapeutics. This will be 20 minutes. And then there will be some time left for question and answer. And then, of course, concluding remarks and further announcement will be done today by Dr. Lakshmi, as will be done every time. We want to sincerely thank Intas, Mr. Chadda and his team, and for the logistics support and the overall connectivity. We want to thank the faculty. This time it is Madras Medical College, uh, and for the case and the all the labor that they have done. We wish to continue this monthly series, and at least 4 more requests have already been processed, and we have already lined up 4 programs in pipeline. We are thankful to Ravi, Dr. Ravi, who is the site coordinator for this program. And every time we'll have a site coordinator whose job would be to coordinate the whole thing. So let us start with the case presentation. Dr. Heli, can you have the slide of Dr. Joby? Dr. Joby Thomas from Madras Medical College will present the case. He is the final year student of DM Neurology from Madras Medical College, Chennai. Without wasting much time, Dr. Joby, please start. You have 10 minutes to go.
So the case, this is a patient named Prakash. He's a 23-year-old male, studied diploma from Chennai, right-handed individual. Now he has come to us with chief complaints of recurrent episodes of inability to use the left eye and deviation of angle of mouth to the right for the past 15 months. Recurrent drooping of left eyelid with double vision for the past 10 months. Inability to close the right eye for the past 5 months. Difficulty in swallowing and speech since past 2 weeks prior to admission. So history, patient was apparently normal 15 months back. That is Symptoms started on October 2018. He complained of development inability to close the left eye with deviation of angle of mouth to the right, which developed over 3 days, and it improved completely over the next 2 months with oral medication. So after the improvement, he stopped medication after it. So 5 months later, that is in March 2019, patient complains of partial drooping of the left eyelid followed by double vision with images horizontally separated on looking at far objects and looking to the left. And subsequently, there was vertical separation of images also. The double vision disappears on closing one eye, and there was no diurnal variation or visual impairment. He underwent treatment for this, some injectables, and with medication he was asymptomatic for the next around 2 months. After 2 months, on May 2019, he developed again partial drooping of the left eyelid, the same eyelid, with a complete restriction of left eye movement over a period of 3 days. So this time it showed only a partial improvement with treatment, and there was a residual drooping and double vision. So he continued treatment for around 5 months. Because there was no further improvement, he stopped the treatment. 1 month after stopping the medication in November 2019, he complained of difficulty in closing the right eye with deviation of angle of mouth to the left and dribbling of food from the right side of angle of mouth, for which he again consulted and was restarted on medication. While he was improving, he developed similar symptoms on the left side of the face over the next 10 days, which did not improve. So around 2 to 3 weeks later, in December 2012, that is 2 weeks prior to our admission, he noticed that he had a cough with nasal regurgitation on drinking water. Later, he developed nasal regurgitation to both solids and liquids with difficulty in swallowing, with slurring of speech and nasal intonation. He did not have any emotional liability or language disturbance. This symptom was associated with the worsening of his double vision that which he previously had. Now, to note is that the nasal regurgitation, the swallowing, the speech completely improved over the period of 5 days with treatment, but there was a persistence of double vision and facial deviation. So the course in the hospital. So the 1 week after the admission, after admission, patient had a complaints of numbness of the left side of face, which developed over a few days, left complete face, and a left-sided numbness of the mouth intraorally. He also had difficulty in chewing on the left side, and currently he prefers to chew on the right side. 1 month after the admission in hospital, he started to complain of back pain that was radiating to the buttocks and also the thighs. Within a week, he had difficulty in clearing the right foot off the ground with aware slippage of supples. Similar complaints started on the left foot after 15 days. In the next 15 days, this was where we had both right and left-sided weakness. Or after the next 15 days, he complains of difficulty in getting up from squatting position, and then progressive difficulty in ambulation over the next 1 month, and he was bedridden. There was no upper limb weakness or any cramps, thinning, or twitching, flailness, or any stiffness. Associated with the symptoms, there was a painful paresthesia that started in both soles and the dorsum of the foot, but later it extended up to the thigh. That is right more than left. The patient did not give any complaint of perianal sensory impairment. A few days after the onset of weakness of lower limbs, he had difficulty in initiating micturition for 2 days, followed by episode of painful retention of urine, which was catheterized, and by this time the patient was non-ambulant. So the patient was able to smell, see objects clearly, and he had no other cranial involvement. There is no cerebellar, extrapyramidal, or cognitive or other, apart from the bladder and bowel, there is no other autonomic involvement. No history of any headache, vomiting, seizures, altered sensorium, or any ear pain, ear discharge. No complaints of any throat pain, nasal block, discharge, or any abdominal pain, vomiting, loose stools. No complaints of rashes, joint pain, oral ulcers, or any fever, weight loss. Past history was not significant. Patient is an occasional smoker and an alcoholic, consumes mixed diet, normal sleep. The treatment history. So the first episode of weakness, where there was a deviation of the face to the right, he was treated with a tablet prednisolone and acyclovir, after which he completely improved. 5 months later, the next symptom starts, that is drooping of eyelids and double vision. This time he was started on IV methylprednisolone, followed by followed by tablet prednisolone and tapered along with pyridostigmine for around 1 month in a private hospital. And he improved totally, and as a result of which he discontinued the medication by himself. After discontinuing, within the next 2 months, he developed again the same problem. This was again treated similarly with steroids, but subsequent this episode had only a partial recovery. Then the next symptom, that is around 2 weeks to 1 month prior to admission, he had a nasal regurgitation that he was put on again pyridostigmine, IV methylprednisolone, followed by prednisolone, and tapered. But the acetylcholine receptor antibody was negative, and so he was referred to our hospital. In summary, here is a 23-year-old male with chronic recurrent progressive neurological illness for the past 15 months in the form of facial weakness on the left side, which improved completely. After 5 months, he had 2 episodes of left-sided ophthalmoparesis, drooping, and double vision within a span of 2 months. And the first episode improved completely, but the second episode only had a partial improvement. Later, 5 months later, again, he had a sequential facial palsy that was first on the right, then followed by the left over a period of 2 weeks, with worsening left ophthalmoparesis that previously he had, with a bulbar symptoms, and numbness of left half of face with difficulty in chewing, with partial improvement of the above mentioned symptoms. Later, he developed asymmetrical progressive painful paraparesis, first involving the right, followed by left. The pattern of weakness was distal, then followed by proximal, with sensory paresthesias extending up to the thigh and an acute painful retention of urine. Without cerebellar, extrapyramidal, higher mental function involvement, there was no symptoms of any other systemic disease, fever, weight loss, or night sweats. So on examination, general examination was unrevealing. There was no neurocutaneous markers, no peripheral nerve thickening. Height and ratio was normal. Vitals were stable. Higher mental functions were normal. MMSE was 30/30. Cranial nerve he was able to, one was normal. Cranial nerve 2, visual acuity on the left side was diminished, that is 20/100, and this was not improving on a pinhole. Uh, Color vision, field of vision was relatively preserved. The fundal picture on the left side, there it showed there was a disc hyperemia with nasal margin blurred, but the right side was normal. So the 346, you can see here the pupils were dilated. It was 5 mm and non-reactive. He had a left-sided partial ptosis, and there was a proptosis compared to the right. There was a left eye proptosis, and the left eye palpebral fissure was widened. You can notice that there is incomplete closure of both eyes, that is left more than right. Sensory examination, there was a fifth nerve sensory B1, B2, V3 diminished on the left 50% to all modalities of sensation, that is pain, touch, and temperature. Intraoral, there was a decreased sensation on the left side of palate, jaw, and cheek. There was a deviation of the jaw to the left on opening, with inability to move the jaw to the right. Patient but was able to relatively open and close the mouth. Corneal and congenital reflex was absent on the left side. Jaw jerk was absent. There was a bilateral facial palsy, element facial palsy, left more than right. 8 nerve was normal. 9, despite he complaining of bulbar symptoms, there was the uvulus midline, palatus mobile, and gag was present, probably recovered. 9, 11, and 12 was normal. Spinomotor system on admission, the spinomotor system was normal in all 4 limbs. Subsequently, after 1 month of admission, when he started to complain of the symptoms, then there is no there is no asymmetry. Tone, there was lower limb hypotonia. The upper limb always the power is 5/5 bilaterally. This was when he started when he started to complain of the weakness. That time, if you see the hip, the flexors were good. Hip extensors were weak on the right side. Hip abductors were weak. Hip adduction was normal. Both lateral rotation and medial rotation rotated was 4/5. The knee flexors were bigger than the extension, that is 4/5. Angle, both dorsiflexor and plantar flexor was 3/5. Inversion and eversion was 4 minus. The left side, the power was normal. This was initially, but over the period of the next 1 month, the weakness became bilateral. It became both to involve distal and proximal, and power was 1 to 2 diffusely, and patient was bedbound after a few weeks of this. The reflexes superficial, corneal and congenital was absent on the left side. The positive findings are there was an abdominal, anal wing and bulbocavernous reflex were absent bilaterally. The plantar flexors, rectal examination showed a decreased sphincter tone. DTRs, upper limb DTRs were normal. lower limb knee jerk was only 1 plus, and angle was absent bilaterally. Sensory on examination, he complained of severe paresthesias, and there was a decreased sensation present from L2 to S3 with an impaired perianal sensation also to all modalities. Cerebellum, extrapyramidal autonomic signs of meningeal irritation, and examination of spine and cranium were normal. Other systems were normal, sir. So in summary, this here is a 23-year-old female male with a chronic recurrent progressive neurological illness in the form of multiple cranial defects involving the left second, third, fourth, fifth, sixth, with left proptosis with bilateral seventh palsy with recovered 9 and 10, and paraparesis with possible motor paralytic bladder and a painful paresthesia and sensory impairment L2 to S3 without higher mental, cerebellar, or extrapyramidal immobility.
Okay, Joe, shall I start, sir? Hello?
Please stop screen sharing. Yeah. Okay.
Sir, shall I start?
1 second. I will have to introduce you, sir.
Yes, sir.
Haley, uh, can you put the introduction slide
Yes,
of
sir.
this?
Yes, sir. Yes, sir. I was waiting for sir to unshare.
Yeah.
So I think
Uh,
what we'll do, we will introduce all three speakers now together. So first moderator is Professor S. Balasubramanian. Can I have Professor Balasubramanian slide, please? Dr. Haley. So first moderator will discuss Professor Balasubramanian. Yeah. He is Professor of Neurology, Institute of Neurology at Madras Medical College. And as you know, he has won the C.V. Chari Memorial Prize during his DM Neurology in 1998. And he was also awarded the Best Doctor Award 2018 by the Tamil Nadu government. His areas of interest are stroke, headache, tropical neurology, neuromuscular disease, movement disorder, etc. So Professor Bala Subramanian is going to dissect the case as regarding the anatomical localization. May I have the second slide, please, for Dr. M. Jawahar? The second moderator will discuss over 15 minutes regarding high-yielding questions related to the quiz. He is also a professor of neurology at the Institute of Neurology, Madras Medical College, and he is in charge of headache clinic and transcranial Doppler study in Madras Medical College. He is an active member in several organizations, and he has published 15 papers in national international journals. His areas of interest are headache, neuroimmunology, and demyelinating disease. Can I have the third slide? Professor Tilangana Ani Krishnan. She is an associate professor of neurology from Sri Manakula Vinagar Medical College, Pondicherry. And she is two papers in national international journals, and she was awarded the gold medals in general medicine, general surgery, and is member to several organizations. She is going to discuss the recent advances with specific emphasis on the therapeutics. I think with this, I hand over the further proceeding to Professor Balasubramaniam and others. Please take it forward, sir. Thank you very much.
Sir, thank you for the introduction, sir. Now we'll go on to the case. Joby, shall I involve the resident also, sir? Joby?
Yes,
As
sir.
you wish. As you wish. Please go ahead. Yeah.
Joby, in brief, tell me you have presented both the history and the clinical findings. Tell me the structure localization in this patient and the evidence for that.
The symptoms.
Hello.
First symptom, although the first symptom started as a left-sided weakness, element facial palsy. That was the first symptom. Left-sided weakness, that is the inability to close the eye with deviation of angle of mouth, which suggests the weakness of upper and lower half of face, left side of face. Possibly it should have been a left-sided facial element facial nerve palsy. This improved almost improved, sir. Improved fully. But the brunt of the lesion in this case, sir, this patient has a recurrent episodes of drooping of eyelid probably due to LPS weakness, Then the next complaint that he had was a double vision, horizontally separated double vision that was more towards distant objects and looking towards the left. So distant object diplopia increasing on for distant objects would suggest a weakness of the lateral rectus muscle, sir. And especially if it's on looking towards the left, it would point out to a left lateral weakness. Possibly it should have been a sick cranial nerve involvement also. Along with it, he had ptosis also and some ophthalmology. Probably so 3 is involved, 6 is involved. You didn't get any evidence for there was some vertical separation of images. Fourth also might be involved. So this on treatment he completely resolved. This episode totally resolved. And after 2 months, he again had the similar complaints. Had this double vision, the drooping of eyelids. Probably it should have been a recurrent same 6, 3, 4, 6, 3 and 6 plus or minus a fourth nerve palsy. Then that lesion localization would be in left cavernous sinus.
What is the evidence for cavernous sinus in that?
Sir, because these three lesions have come together, sir. 3, 4, 6, sir. So it probably the site of localization most commonly will be cavernous sinus. We also have other evidence further down the case, sir. Other evidence for cavernous sinus, sir.
No, it can be only in the cavernous sinus. Can it be in the superior orbital fissure?
Sir, he has not complained of vision per se in the history, sir. We don't know about the trigeminal sensory, facial nerve sensory came later, sir. At this point, we don't know whether we cannot take that clue, sir. Vision was not impaired, sir. So it's unlikely that the lesion should have spread into the superior orbital and involved the optic nerve, sir. So
superior orbital fissure can have without involvement also. V1.
Yes.
Sorry, optic nerve. Only when it goes more anteriorly in orbital apex, you will get involvement. So it can still be a partial superior orbital fissure also, not only cavernous sinus. It can be in the cavernous sinus, it can be in the superior orbital fissure, or it can be the multiple involvement of the multiple cranial nerves. And it can be, see, already they have, in the history wise, they have put as peridostigmine was also put. Still it can be a neuromuscular problem. I mean, the neuromuscular junction problem, but history wise, is there any evidence for neuromuscular junction? Is it against the neuromuscular junction problem in this patient?
There was no diurnal variation of symptoms, sir. And then there was negative history down the line. There was so much of negative history, and our examination finding was not suggestive of a neuromuscular disorder, sir.
No, the ophthalmoparesis, is it unilateral or bilateral?
Ophthalmoparesis is unilateral. The right side was totally normal. That is also against it.
There was no bilateral ptosis at all in this patient. Generally, you suspect a neuromuscular junction problem and there is a bilateral asymmetric ptosis. Though it may start unilaterally, but later it become bilateral. Here, the ophthalmoparesis has been strictly unilateral. Yes, and there is a bilateral facial palsy, but the ophthalmoparesis is strictly unilateral. Because why I raise this point is, the patient has been put on twice peridostigmine along with steroids. Okay. So, but it is an unilateral ophthalmoparesis occurring recurrently on the same side.
Same side, sir.
So this will negate an neuromuscular junction problem. Okay.
Yes, sir.
Then
after this, he again developed a bifacial palsy with a bulbar symptoms, with both nasal regurgitation and difficulty in nasal intonation of speech and nasal regurgitation with difficulty in swallowing. So he has developed a 10th nerve palsy also, sir. So over a period of 1 month, he developed sequential facial nerve palsy, bilateral, 11th, 7th nerve, and 10th nerve, sir, and a 10th nerve plus or minus a 9 over a period of 1 month. So this localization should be separate from the cavernous sinus, and I would like to put this in the basal cistern, sir. In the lesion is extraaxial intracranial, because it's extraaxial because there is no other long tract signs that suggesting of a intraaxial lesion. So the lesion is an extraaxial lesion.
What are the clinical signs of an intraaxial lesion?
Sir, intraaxial lesion.
Clinical signs of an intraaxial lesion.
Intraaxial lesions, there is a long tract sign, sir. INOs are common in INO suggested intraaxial lesions.
Of INO,
sir. And then the onion peel like sensory loss, sir. That can
different patterns of sensory loss in the trigeminal. What are the different patterns?
Sir, patterns of sensory loss. One will be your in the distribution of the nerves, sir. V1, V2, V3, sir. The second pattern of the distribution is with the lamination, sir. In the brainstem, the spinal tract, it's divided into three, sir. That is your pars oralis, pars interpolaris, and pars caudalis. Where pars caudalis extends up to the your C2, C3, and your pars oralis starts from the mid-pontine level. So any lesion that can disproportionately affect either the pons, medulla, or the cervical spine can cause a difference of can cause a onion peel like pattern, sir. So that
Onion
would,
peel pattern, balaclava sensory pattern,
and then there can have a dissociated like dissociated sensory loss, sir.
dissociated sensory.
Dissociated sensory loss where the so pain and temperature is lost, and but the touch is normal, or separately the mesencephalic nucleus can be involved, or
Okay.
principal sensory.
So next, what is the
Uh,
other structures involved in this patient?
Other structures, sir. After this, he had a fifth nerve involvement, sir. Fifth nerve, as per the history, it is V1, V2, V3, sir. So to have such an extensive involvement, it is not intracranial, sir. It can be either in the subarachnoid space or at the
No,
level of
V1,
Gesserian
V2,
ganglion,
V3
petrous
sensory.
apex. At the level
V1,
of Gesserian
V2 sensory
ganglion
and
on the
motor.
petrous apex.
Motor also.
V3 is also involved, sir. So we cannot put this lesion at the cavernous sinus, sir, because V3 gives before the cavernous sinus. So we have to put this lesion somewhere around the petrous apex, around the Meckel's cave, sir. So this lesion, this facial sensory loss should be secondary to either the lesion at around the Gesserian ganglion with also the motor root, exiting motor root involvement of the mandibular nerve, sir, or possibly around the petrous apex, sir. So
Where does the
after
mandibular nerve exit?
the mandibular nerve exits via the oval, sir, foramen oval, sir,
Foramen ovale.
for around the foramen oval. The petrous apex or the Meckel's cave, it can be involved together, sir. After this, the patient had a totally different site of involvement, wherein he had initially a foot drop, sir. He had initially complained of back pain, then followed by a radicular or a radiating type of pain to the right side, to the right leg, and then after a week he complained of foot drop, sir. So the localization for foot drop, it can be either a neuropathy where it can be a peroneal sciatic, or it can be in this case more likely it should be a radicular. It should be that foot drop should have been caused by a radicular involvement on the right side. Specifically, it should have been a L5S1. It should have started somewhere around as an L5S1 radical, sir. Then, over the period of 15 days, it subsequently spread to the other side, and then there is a involvement of the urinary retention, sir. Hello, sir.
What is the evidence for radical?
Sir, uh, the evidence for radical is that there is a back pain, there is a radiating pain, sir, and the weakness is corresponding to an L5S1 dermatomal pattern, sir. L5S1 radicular pattern, sir. The weakness.
That's what, how would you say
Other
that?
on examination,
Radical pattern.
yes, sir. On examination, if you take the examination findings also into consideration, he also had both inversion and eversion weakness, and also eversion weakness, and also there was a decreased reflexes, and also I didn't mention the examination. Medial hamstring also was decreased, sir. So and angle is also absent, sir. So I think there is an S1 involvement also, sir. So
Is it only distal or is it distal and proximal weakness?
It started as a distal predominantly at the level of L5S1, sir, and over a period of the next 1 month, it has picked up the other roots to involve total power is 1 to 2. So from L1, L2 to around S3, there should have been total root involvement, sir. Also, there is another thing that is favoring is he has a motor paralysis. He had an episode of acute retention of urine that was painful. Probably that should have been related to the motor radicular involvement of the S1, S2, S3, and it could have been a motor paralytic bladder, sir. Then also he had a sacral anesthesia again that
Why
can
can't it be in the cord? Since he has progressed to almost complete paraparesis, why can't it be in the cord?
It can be in the cord, sir, but he had sensory at that time, sir. Usually cord at the sacral level will have an autonomous bladder, sir. They will have a incontinence. They cannot feel the bladder and they cannot initiate the observation, sir.
He developed painful retention and catheterized. Okay.
Yes, sir.
Based on the weakness, can it be in the cord?
There is no cord. We didn't get any evidence for cords. Still, cone is an unlikely cause, sir. we didn't get any evidence for COD, sir. There is no human signs, sir. And purely only the motor component of this fiber was involved, sir. So it could have probably, considering the whole clinical picture, where it was a radicular type of pain, asymmetrical, areflexic, painful, radicular type of pain. It could have been the roots per se that has caused this, sir. We
That's what
cannot rule out a COD, but
there is no pyramidal sign at all.
yes,
All
sir.
reflexes are sluggish to absent. There is no definite level. Okay,
Yes,
it's
sir.
the sensory started initially in the foot, and then there was paresthesias in the thighs, asymmetrical. The weakness is initially started as asymmetrical, flaccid, paraparesis with bladder, and there is no definite sensory level, and there is no evidence for any corticospinal tract involvement at all in this patient.
Yes,
So it
sir.
is an areflexic, asymmetric paraparesis, which started initially distally, subsequently involved proximally. So the lumbosacral roots are involved with bladder involvement, or probably a motor paralytic bladder. Okay,
Yes,
and there is a perianal sensory impairment. There is this one, anal tone, anal vein. Can it be in the conus?
the corners usually are not painful. They are usually more symmetrical, and the weakness, the motor component is not so predominant, sir. It is unlikely to be a
Pure
cone.
conus, pure conus lesion produces with saddle anesthesia with almost symmetrical saddle anesthesia and the bladder symptoms and perianal sensory impairment. But usually you'll have the whatever the ankle reflex will be there if it is a pure conus lesion. Ankle
Pure
reflex,
corners lesion, it can be preserved.
ankle reflex.
Can be preserved, sir.
It will be preserved. Pure conus. So generally pure conus is not. I mean, it is very difficult. It is not a very common thing, but usually it will be a cauda conus lesion only. Okay, there you can have both ankle reflex. Everything will be absent.
Yes, sir.
Okay,
Yes, sir.
so this is probably an asymmetric cauda equina lesion which is presented later. Okay, summing up everything, tell me in a nutshell, where is the brunt of the problem in this patient?
As you can see, the brunt of the problem, brunt of the problem is in the cavernous sinus, sir. It should be in the left cavernous sinus, sir. So it started as a 3, 4, 6 recurrent episodes of 3, 4, 6, and the lesion should have extended anteriorly, sir, to superior orbital fissure and left orbital apex. Why? This is the evidence by he had a visual acuity was diminished. There was some evidence of optic neuropathy with the disc hypoplasy. So there was an optic neuropathy plus he also had proptosis. So that points to some retroorbital mass structural lesion that should have caused the proptosis. And so the lesion extending anteriorly, the cavernous sinus lesion extending to superior orbital and left orbital apex, and posteriorly, because what the three also involved, we
Yes, Joby.
explain it by the posterior tract, the lesion. This is the brunt of the lesion, sir. Uh, this is the brunt of the lesion. He also had a 7 and can be subjected to this, and he had a like a coda equina, maybe an arachnoiditis. Secondary to an arachnoiditis, he must have a lumbosacral radical neuropathy, sir. So this considering all these three things together,
Your audio is not
was
clear.
very responsible. Very.
Come close to the mic. Joby, come close to the mic.
Yes, sir. Sir,
Proceed.
considering this all things together, that is this cavernous sinus lesion that has extended both anteriorly and posteriorly with a basal cistern lesion, prepontine lesion, and a lumbosacral or a coda equina or maybe an arachnoiditis. The important clinical clue in this case is the patient was always steroid responsive, at least initially, where the total symptoms are totally resolved. So if the etiological wise, sir, I would like to consider lesions that are chronic and it has a producing a mass effect with that was initially at least responsive to steroids. Initially responsive to steroids. So etiologically, first thing I would like to consider is it might be a sarcoidosis be a possibility, sir. Sarcoidosis, wherein it can per se cause bilateral facial nerve palsy, may not be a structural lesion. Followed by there is a granulomatous lesion in the cavernous sinus extending, and sarcoidosis can pick up the root and present as a coda equina syndrome. That is initially at first responding to steroids. Other inflammatory non-infectious diseases, maybe like IgG4 also can have a granulomatous presentation that is responsive to steroids. Then they can have especially responsive to steroids, lymphoreticular neoplasms like a lymphoma that responds very nicely to very as a good steroid response. Lymphoma can present as a similar clinical picture, sir.
What about
Then
infections? What about infections?
infection, sir. Infection, sir. It is a possibility, sir. But the thing is, the steroid responsiveness to steroids and the absence of any other fever, weight loss, it is goes. It's unlikely to be infection, sir. But if you consider infection, sir, I would like to consider tuberculosis as the first infection, sir, possibility in this patient, sir. But it is unlikely because it is of steroid responsive. It is very at least steroid responsive for almost an year, without
Connective
any
tissue
other.
disorders.
Sir?
Connective tissue disorders.
Connective tissue disorders, essentially can have vasculitis, maybe with the granulomatous like Wegener's. Wegener's can have granulomatous with polyangiitis, but there are negative histories for this. Wegener's usually have sinusitis, respiratory illness.
Toby, which
So
viral
it
infection?
is unlikely to be Wegener's chunks. Yes, sir.
Which viral infection will cause multiple cranial palsy and lumbosacral radiculopathy?
Sir, CMV can cause multiple cranial
Cytomegalovirus. Yes.
cytomegalovirus. Sir, we can also consider HIV, but not HIV per se. HIV with something superimposed, like HIV has caused a lymphoma, or an HIV has caused some granulomatous lesion, cryptococcus, or something. But again, the
Opportunistic
steroid
infection.
responsiveness for a long time
Mm.
is an against an
Yes.
infection for this patient, sir.
No, the steroid responsiveness is there, but see, the first two episodes of steroid fully responsive, but subsequently the third and fourth, even with steroids, the patient has gradually progressed. Okay,
Yes, sir.
so steroid responsive is initially, but subsequently the steroid is not fully responsive.
Yes, sir.
Okay, it is more than steroid responsive disease.
Yes, sir. So
Okay,
this can be tuberculosis also. We will have to work up for tuberculosis also in this patient, sir. Definitely.
okay. So in the order of priority, which will you put first?
Uh, Priority first will be non-infectious inflammatory disorders only, sir. First, sarcoidosis will be high up in the list, sir. Sarcoidosis,
Okay,
IgG4.
okay.
Then a lymphoma
IgG4,
also.
what else you expect in IgG4?
IgG4, they can have other manifestations, sir. Usually
Like,
they'll have pancreatitis, abdominal retroperitoneal fibrosis.
mm,
Those other manifestations will be there, sir. Usually,
yes,
commonly in IgG.
other serosal inflammations.
The polyserous inflammations will be there, sir. So that is unlike didn't give any of those history.
But
Then
still,
it can
that is high possibility because it is partially responsive to steroids.
steroids, sir. And then I would like to consider lymphoma or a tuberculosis, sir.
Okay, or lymphoreticular malignancies.
Lymphoreticular malignancy or a tuberculosis, or it can be again one more way down the order. It can be a leptomeningeal mets also, but he has not complaints of any systemic features. It should also be kept in my leptomeningeal metastasis.
So in summary, see this. What I like to summarize is in this patient, the structures localization, as he said, there is a bilateral facial palsy started on the left, completely improved. Then subsequently right element facial palsy, which the patient had the left, two episodes of left side ophthalmoparesis. First episode completely improved. Second episode partially improved, predominantly involving the 3, 4, and 6. Subsequently, the patient developing uh, uh, sequential facial palsy, again right and left. Right completely improved, left partially improved, but still the patient presenting with ophthalmoparesis worsening and some bulbar symptoms which has improved, probably involvement of 10. So some of the symptoms have improved with steroids, some of the symptoms static with steroids, especially ophthalmoparesis. But the crux of the problem, the patient later developed another site of lesion in the lumbosacral region, probably involving the lumbosacral roots, asymmetrical, right more than left, leading on to paraparesis. So the sites of lesion are, see, the one thing is the brunt of the lesion is in the left-sided cavernous sinus, as you said, extending anteriorly into the orbital apex because there is involvement of the optic nerve per se, And then posteriorly, there is some involvement in the lower cranial nerves, especially 10th and then 7th bilaterally. So probably there is a structural lesion. Why structural lesion? There is proptosis involving the left-sided orbit. So probably there is a structural lesion, which can be a granulomatous lesion or any infiltrative lesion. Brunt of the problem is in the cavernous sinus as far as the intracranial aspect is concerned. Next is the lower spinal involvement, is lumbosacral radiculopathy, which started as initially distally, subsequently proximally with bladder involvement. So these two sites of lesion, as you said, partially steroid responsive. The possibilities I like to put is first is sarcoidosis, as you said. Second is IgG4 disease. Third is still I'll consider infectious problem, though it is only initially responds only to steroids, but subsequently there is a complete progression with even with steroids without any other drugs. So probably tuberculosis or other infectious etiologies. And fourth is lymphoreticular malignancies. Okay, sir. Investigations.
Okay. So the routine investigations were normal. There was a mild minimal elevation of AC levels 54. The CSF, the opening pressure was normal. Cytology had no malignant cells. Protein, there was an elevation of protein, but all the other tests, Gram stain, AFP, gene, fungal elements, and VDRL was negative. The other workups were normal: ECG, X-ray, CT, abdomen, pelvis. So we took an MRI brain with contrast. What you can see in this MRI is there is there is a paracellular mass in the left and in the right. Paracellular mass is in the left and the right. It's extending into the cavernous sinus, and it is contrast enhancing. Contrast enhancing lesion. There is some mild leptomeningeal enhancement also. So this is a zoomed in. It is more on the left, but it is bilateral. The left is actually bigger, so that's why the patient has had a symptoms of left cavernous sinus. This is an axial T1 contrast section. So here I'll just do it. Here again there is a left-sided cavernous sinus. There is a contrast enhancement, and this enhancement, it is entering into the orbit. It is around the optic nerve. It is tracking the optic nerve with some mild proptosis. And the lesion, you can see that the cavernous sinus lesion on the left extends backward into the cistern at around the pondomesencephalic junction. So that maybe the lesion must have tracked backwards from the petrous apex in the down the clivus around
There is another point I like to the pituitary stalk is contrast enhancing severely. The pituitary stalk on the left side picture is contrast enhanced, which condition will get severe pituitary stalk enhancement.
Sarcoidosis can have pituitary involvement.
Yes.
So lymphoma also can have, but sarcoidosis can have. So there is a lesion that is extending down that can explain the bulbar symptoms. So there is an soft tissue, enhancing soft tissue that is in the left paracellular, left cavernous, anteriorly in the orbital fissure, optic nerve, and adjacent conal fat. Inferiorly, it is up to the clinoid and the in the internal carotid artery. Right side paracellular is more confined. So again, this was a CT. You can see that the soft tissue hypodensity is extending. CT paraneser. Possible differential diagnosis: tuberculosis can come above lymphoma. It's neurosarcoidosis, IgG4 lymphoma, and tuberculosis.
So what about connective tissue disorder?
Sir, we did a connective tissue disorder. We worked up for that, sir. Connective tissue disorder was negative, sir, and he did not have any other associated symptoms of like rash or purpura, oral ulcers, arthritis. So and the profile was negative, sir. Connective tissue profile was negative. IgG4 was negative 2 times. We went further to do a PET study, sir. So in this PET study, what you can see here is there is a so you can see there is a metabolic active tissue here. So what is this? This is the metabolically active soft tissue thickening. You can see that the thickening is extending anteriorly. That is from the left cavernous sinus extending anteriorly and also posteriorly. Thickening extends posteriorly. So there is a metabolically active tissue from the cavernous sinus, both extending both anteriorly and posteriorly. As sir told, there is a mild thickening of pituitary infant, and there's an increased metabolic activity in the pituitary also. The spinal, what you can see is there is some soft tissue growth here, and there is a increased metabolic activity that is extending. What the report has shown, dural thickening in the lower dorsal entire lumbar spinal canal, showing diffuse increased metabolic activity. Also, we got the MRI spine with contrast lumbar spine. There it had shown that there is a soft tissue thickening in the cauda equina rootlets. and the possibility of a lymphomatous deposits to be considered. So then we consulted with a neurosurgeon, and then we went further to do a biopsy. Uh, the biopsy report had shown that there is a lymphoproliferative disorder. It was after immunohistochemistry. They had committed that it is a non-Hodgkin lymphoma with the B of a B cell type. So that was the final conclusion of this case.
Biopsy site. You didn't mention the site.
Site, it was taken from the lumbar, sir.
Spine.
Lumbar, the dura and the
lumbosacral.
During the biopsy, the neurosurgeon had mentioned that the lesion has encased the nerve, and the dura is thickened, and the lesion has encased and infiltrated the nerve also. It totally infiltrated the nerve. So it was there's a neural infiltrate. It was more of an infiltrative granulomatous infiltrative lesion. So its clinical picture also fits, and it was a non-Hodgkin's lymphoma.
So this is actually this patient. So to summarize, this patient was quite challenging patient to us because he was actually referred as a case of myasthenia and prednisolone. Sorry, pyridostigmine. So, but over the course, when in our hospital, the patient developed sequential symptoms, which finally evaluated our differentials, which we considered as Joby had pointed out, and finally we came to the conclusion only with biopsy. Of course, we planned a biopsy intracranially itself, but the patient was not willing at that time since he was ambulant. But subsequently, after the development of paraparesis, the patient agreed for biopsy. So the diagnosis was a bit late in this patient. Probably, I mean, we did extensive evaluation initially to find out about the cause, but only after the development of paraparesis we could make out the diagnosis. So actually this PET scan helped a lot, and I should thank Professor Lakshmi Narasimhan for organizing the PET scan in this patient. Thank you, sir.
Thank you. Thank you, sir. And Dr. Dr. Jawahar?
Yes. Shall I start, sir? Shall I share?
Yeah.
Thank you very much, sir. So I'm going to talk about the common clinical exam questions regarding this case. Because this case, we know that the multiple cranial nerves are being picked up, and many of the cranial nerves are clustered around the cavernous sinus. Definitely, they are going to ask why you are telling it's a cavernous sinusation. We know very well that it's the involvement of third, fourth, and sixth, and V1 and V2. All these cranial nerves, if it is involved, we can surely say it's a cavernous sinus lesion. But in this patient, apart from these nerves, the left optic nerve also is involved, indicating that the extension into the orbital apex, and also the seventh nerve, ninth and 10th involved. Probably, I think from the cavernous sinus, it would have extended posteriorly to the petrous apex involving the seventh nerve, or even in the clivus region to involve the ninth and 10th. So if the cavernous sinus thrombosis is there, what are the additional findings apart from these things? The patient will have a proptosis and chemosis of the conjunctiva, and later initially to start with it will become a unilateral lesions, and then a cavernous sinus thrombosis will spread to become a bilateral signs. And if the cause is a carotica cavernous fistula, you can have additional findings of pulsatile proptosis, and you can auscultate a buoy over the over the eye. And as already mentioned, discussed about the cause of various cavernous sinus lesions, the main thing, non-infectious granulomatous lesions are quite common in the cavernous sinus area. One is Tolosa Hunt, but in this case, Tolosa Hunt is not fitting because other cranial nerves like the 7th and 9th cannot be involved. Only it is only focal granulomatous lesion involving the cavernous area. And vaginous granulomatosis and Church-Strauss, sarcoidosis, and hyper IgG4 syndrome. So all these non-infectious granulomatous lesions can produce sort of problems. And coming to the infections, bacterial infection, tuberculosis, and fungal infection in the case of mucormycosis and aspergillosis, especially the angio-invasive fungal infection like aspergillosis can produce a cranial nerve palsy at the distant site apart from the focal fungal infection infested area. And malignancy, as already discussed, lymphoma, leukemia, myeloma, neuroblastoma. The neuroblastoma arising from the cranial nerves which are traversing the cavernous sinus, and metastasis. Metastasis from CA breast or small cell lung carcinoma, all these things can have a metastasis in the cavernous area. And the intracavernous carotid artery aneurysms, pituitary apoplexy, sudden hemorrhage into the pituitary can cause a bilateral cavernous sinus lesions. And tumors, benign tumors like meningioma, schwannoma, and hemangioma, all these things can produce a cavernous sinus lesions. So they will ask about the various etiological causes of cavernous sinus lesions, and all the students should prepare this thing to tell about all the causes. And there are certain cavernous sinus mimickers, especially the myasthenia gravis. The myasthenia gravis can produce ophthalmic paresis, but in this case, the facial sensory impairment and other fifth motor involvement, all these things will not occur. But this, apart from myasthenia gravis, you can have orbital pseudotumor. Orbital pseudotumor only, it's actually, it causes the swelling of the extraocular muscles. That swollen extraocular muscle can compress the third, fourth, sixth nerve, can mimic like a cavernous sinus syndrome without involving the cavernous sinus. And hypertrophic pachymeningitis, the thickening of the dura will cause compression of the cranial nerves. That will produce a cavernous sinus lesion like. And craniopharyngioma, a tumor that is arising above the tubercular pituitary fossa, that can also produce a cavernous sinus lesion, and pituitary apoplexy. These are all certain other conditions which can produce cavernous sinus lesions. And definitely when the ocular nerve is involved, they will ask about the pupillary light reflex. When the optic nerve lesion is there, especially for example in the right side, direct light reflex will be absent, and the consensual reflex on the other side, the left side, will be absent. And there will be a relative upfront pupillary defect. If you show the flashing light from the normal side to the abnormal side, normal side will react, and abnormal side, when you show the flashlight, that people will go on dilating. That is known as Marcus Can pupil. And if there is a right, for example, right third nerve lesion, the direct right reflex will be absent, but the consensual reflex on the other side will be present because of the intact second nerve. And they will ask about the Orgel-Robertson pupil and Holmes-Addy pupil. Orgel-Robertson pupil is nothing but a bilateral small pupil, not reacting to light, but reacting to accommodation. The accommodation retained. So neurosyphilis and diabetes are the causative factors. Holmes-Addy pupil is nothing but a tonically dilated pupil. When compared to the AR pupil, which is bilaterally small pupil, the Holmes-Addy pupil is a tonically dilated pupil that reacts slowly to the light, but reacts definitely to the accommodation. The Holmes-Addy pupil is a congenital problem. And they will ask how to test each and every extraocular muscles. It is very simple. If they ask to check the right superior rectus muscle, you have to ask the patient to abduct the right eyeball. Ask the patient to abduct the right eyeball and then look up. If you are asked to test the right inferior rectus, ask the patient to abduct the right eyeball and then look down. If they ask to check the right superior oblique muscle, you have to adduct the right eyeball and look down. And if they ask to check the inferior oblique muscle, you have to adduct the right eyeball and look up. So these are the various method of testing. And every muscle has got a primary, secondary, and tertiary action of this thing. If you get a superior rectus, the primary action is elevation, secondary action is intorsion, and the tertiary action is adduction. Inferior rectus, the primary action is depression, secondary action is extorsion, and the tertiary action is adduction. Superior oblique, the primary action is intorsion, and then depression, and then abduction. Inferior oblique, extorsion is the primary action, elevation and abduction are the other actions. So all the oblique muscles are abductors, that we have to remember. And they will ask this sort of questions. And medial rectus laterals, everybody knows that action and abduction. And how to test the fourth nerve in the presence of third nerve is a very common question. You have to fix the congenital blood vessel in the affected eye and ask the patient to look at the opposite shoulder, or otherwise look at the tip of the nose and look for the intorsion of the eye. This is because the inferior rectus, because third nerve palsy is there, inferior rectus will be weak. He cannot look down. So only thing we can check the intorsion, and that can be tested like this. Trigeminal nerve, they will ask about the sensory divisions V1, V2, V3, and this ophthalmic division comes out through the skull, through the superior orbital fissure, and maxillary division through the foramen rotundum, and mandibular division through the foramen ovale. And there are separate branches for ophthalmic division. You can have frontal, lacrimal, nasociliary, and maxillary division. It has got infraorbital, zygomatic, supraalveolar, pterygopalatine, and mandibular division is buccal, lingual, inferior alveolar, auriculotemporal. So all the three branches got a meningeal branches also. One important thing is trigeminal nerve has got a three nucleus. One is a mesencephalic nucleus, is purely for proprioception. Second, pons is a purely motor nucleus. And third, pontomedullary area where the sensory nucleus and the nucleus of spinal tract of trigeminal nerve is present. Checking the V1, V2, V3 is very important. The V1, the tip of the nose, side of the nose, and over the periocular region, ocular, periocular, and over the forehead up to the vertex, middle of the vertex. And then for V2 region, it is upper lip, cheek area. For V3 region, it is the chin, jaw, and the temple region. When you come to, when the lesion is an intraocular involving the spinal tract or trigeminal, you can see the onion peel sensory impairment. For example, if the perioral area and the tip of the nose is involved, probably the lesion will be sitting in the topmost portion of the spinal tract, that is cranial portion of the spinal tract. If the pre-auricular region of there is a sensory impairment is there, then the lesion will be in the caudal aspect of the spinal tract, probably C1, C2 region. So that we have to explain to the examiner when they ask. So ophthalmic division testing will not be complete without doing a corneal reflex. And they will ask about the muscles supplied by the trigeminal nerves. So all the muscles of mastication, medial and lateral pterygoid, masseter, temporalis, and anterior biliodigastric, because the posterior biliodigastric is supplied by the facial nerve, mylohyoid, tensor vellopalatine, and tensor tympanic. And they will also about the jaw opening actions and what are the muscles responsible for that. Jaw opening is done by the both lateral pterygoid and mylohyoid. Jaw closing by masseter and temporalis. Jaw lateropulsion by the opposite lateral medial pterygoid, and jaw protrusion by both side lateral medial pterygoids together. Then coming to the branches of the seventh cranial nerve, you know very well that they got two roots in the motor root and sensory root. The sensory root has got a special significance in the seventh nerve. It has got a sensory fibers and secretomotor fibers to the lacrimal gland and the sublingual and the salivary glands, and also special sensory fibers for taste sensory fibers in the anterior two-third tongue. So all the sensory, this type of sensory, they'll come out as a nervous intermediates and join together with the motor root, and they enter into the facial canal. And first bend, there is a geniculate ganglion. From the geniculate ganglion, the greater petrosal nerve emerges, which supplies the lacrimal gland. And next nerve is nerve stapedius. Actually the nerve stapedius function is prevent the stapes intact when the loud sound happens. So if the nerve stapedius is damaged, the patient will have hyperacusis. And the facial nerve, before exiting from the stylomastoid foramen, it gives out the chorda tympani branch. The chorda tympani gives the taste fibers to the anterior two-third, and also the secretomotor fibers to the salivary glands, submandibular and sublingual glands. After exiting from the stylomastoid foramen, the first branch is posterior auricular nerve, which supplies the anterior and posterior auricular muscles and occipita frontalis belly. And second nerve is nerve to posterior digastric. Third nerve is nerve to stylohyoid. And finally, the facial nerve divides into 5 terminal branches. One is temporal, another is zygomatic, third is buccal, fourth is mandibular, fifth is cervical. And they will ask about the muscles supplied by the facial muscles. All the muscles of facial expression is supplied by the facial nerve, like frontalis, orbicularis, orbicularis, oris, vaccinator, platysma, stapedius, stylohyoid, posterior biliodigastric, occipitalis, anterior and posterior auricular muscles, corrugator, superciliae, cruciris, nasalis, and zygomaticus alinaceae. And coming to the ninth nerve, the only muscle motor supply from the ninth nerve is stylopharyngeus. All the other are sensory branches. So regarding the localization of lesion, how to localize is whether it is intraxial lesion or extraxial lesion. Already it's discussed presence of INO, and if there is a bilateral ptosis with bilateral superior rectal palsy, it indicates the third of nuclear lesion. And if you feel onion peel type of sensory loss, then it is involving the sensory tract of the trigeminal. And if you find a long tract signs, also it's intraaxial. And there is a disproportionate involvement of pain and temperature and sparing of the posterior column also. In that type of impairment, you can say it could be intraaxial. Extraaxial locations, either in the subarachnoid space, like basal systems, and specific locations like a cavernous sinus, CP angle, skull base area, etc. And if you find a multiple cranial nerves which are non-adjacent, multiple cranial nerves are involved, then you can say it's a extraaxial. When all the three divisions of the trigeminal nerve, sensory divisions, along with the motor fibers, motor component, then definitely it could be extraaxial lesion, because the intraaxial cannot produce all the sensory and the motor components of the physical nerve. So coming to the differential diagnosis, the first is CNS lymphoma. Why we are insisting on the CNS lymphoma means CNS lymphoma can respond to steroids, recover partially, and then again it will come. It can present in 4 ways. Either the CNS lymphoma can present as a CNS parenchymal lesion, or it can present as leptomeningeal lymphomatosis, or it can present as a lymphoma with vasculitis, that thereby causing cranial neuropathy or a peripheral neuropathy, or a neurolymphomatosis. Neurolymphomatosis is nothing but infiltrative lymphoma, where it will infiltrate the roots, plexus, peripheral nerves, and cranial nerves. So this neurolymphomatosis is very difficult to treat. And other differential diagnoses are leptomeningeal metastasis due to other malignancies, sarcoidosis, tuberculosis, hyper IgG syndrome, and HIV, especially the CMV, herpes zoster, paraneoplastic conditions, and Lyme's. In the American area, Lyme's is the most common condition which can cause cranial nerves and also radiculopathy. So there are causes of multiple cranial nerves. What are the causes of multiple cranial nerves involvement? Especially commonly the diabetes, hypertension, and giant cell arteritis, they can produce multiple cranial nerve involvement, and sarcoidosis also. Vasculitis due to all connective disorders, including SLE, and otitis media. That otitis media it can cause Grendigo syndrome, thereby involving the sixth nerve, fifth nerve, seventh nerve, and probably ninth and tenth also. Malignant activities externa is due to Pseudomonas infection. It can cause skull base osteomyelitis involving multiple cranial nerves. An infiltrating process at the skull base, that is maybe due to skull base tumors like chordoma, chondroma, chondrosarcoma, or skull base metastasis like prostate malignancies and breast malignancies, and brainstem infarct like lateral medullary infarct, arterial dissection, vertebral artery dissection causing lateral medullary infarct causing cranial nerve problem, and pituitary apoplexy, and compression by aneurysms like PCOM aneurysm or a basilar artery aneurysm can produce a multiple cranial nerve. Trauma, we already know the traumatic third nerve palsy, second nerve palsy, and sixth nerve palsy. Craniopharyngioma, nasopharyngeal carcinoma, and already we discussed about all the cavernous sinus mass, meningioma, schwannoma, lymphoma, metastasis, CP angle tumors, and infection like herpes zoster, cytomegalovirus, HIV, neurosyphilis, Lyme's, and diphtheria. And Guillain-Barré syndrome, we already know the Miller-Fisher type of Guillain-Barré syndrome involve the multiple cranial nerves and multiple sclerosis. These are all the causes of multiple cranial nerve involvement. And I thank you very much. And I just given a significant questions, but there are many questions which I cannot tell everything in the constrained time. So I would like all the postgraduates to read all about the cranial nerves and their branches, origins, everything. Thank you very much. Thank you, sir.
Yes, Dr. Tilangana.
Dr. Jawgar, stop sharing. Dr. Jawgar, stop sharing.
Yes.
Yeah.
Thank you, Dr. Jawar and Dr. Balasubramanian. Wonderful job, and I think Dr. Tilangana is ready. In the meanwhile, I must once again thank my co-course director, Professor Lakshmi Narsihan, for his extraordinary efforts in bringing up this webinar series.
Sir,
He has really worked very hard and put a
sir,
lot of thoughts. Thank you very
it's
much.
my honor to be associated with you, sir. You are the inspiration for the entire country.
No, not at all. Actually, I must confess that here you have done really a more harder labor than me, and I must appreciate that in front of everybody. Thank you very much.
Thank you, sir.
So, Dr. Tilangana, please.
Good evening to all. I would like to thank Dr. Lakshmi Narasimhan sir for providing me this opportunity.
Closer to the mic. Closer to the mic, please.
I will be presenting on recent advances in CNS lymphoma. This is the outline of my presentation. I will start with brief introduction followed by advances in diagnosis, including advanced imaging techniques and biomarkers, followed by advances in treatment in primary and secondary CNS lymphoma. Primary CNS lymphoma is an uncommon extranodal NHL without evidence of systemic disease. Primary cerebral lymphoma is the most common involvement. Primary rectomeningeal lymphoma without a synchronous cerebral lesion is rare. Primary intraocular lymphoma
Dr.
involves
Telangana, please speak louder, please.
primary intraocular lymphoma involves the posterior segment of the eye. Primary spinal lymphoma and neurolymphomatosis are rare presentations. Neurolymphomatosis involves the lymphomatous invasion of the cranial nerve and the peripheral nerve roots and plexus. Leptomeningeal metastasis is the common presentation of secondary CNS lymphoma. Parenchymal brain metastasis is comparatively rare when compared to the leptomeningeal metastasis in secondary CNS lymphoma. Intramedullary spinal dissemination and neurolymphomatosis are rare presentation in secondary CNS lymphoma. Diagnostic delay is often an issue in primary CNS lymphoma, considering the rapidly progressive course of the disease. Serotaxic brain biopsy is the gold standard procedure involved in the diagnosis of primary CNS lymphoma. CSF cell count, protein, glucose, CSF cytology, flow cytometry, IGF gene rearrangements are common tests involved in the diagnostic procedure of primary CNS lymphoma. In CSF analysis, um, we find lymphocytic predominant pleocytosis and elevated protein with normal glucose. Bone marrow aspirate and biopsy, fundoscopy and slit lamp examination, whole body FTG PET and testicular ultrasound are done to evaluate the extent of the disease. Quantitative diffusion weighted imaging is done to differentiate primary CNS lymphoma from other metastatic metastatic or high grade gliomas. Um, because of the hypercellularity of the primary CNS lymphoma, the diffusion restriction is well seen. It appears hyperintense on DWA and hyperintense on ADC. ADC threshold value of equal to or less than 1.1 into 10 power minus 3 millimeters per second is used to differentiate primary CNS lymphoma from GBM. Decrease in ADC value suggests increased cellularity. Increase in ADC value during treatment suggests positive response to therapy. Decrease in ADC value suggests tumor progression. There is a significant overlap in agents of ADC between lymphoma and GBM. So ADC alone might not be sufficient to differentiate lymphoma from GBM. So this is a case of GBM where there is a typical finding of primary CNS lymphoma with very low ADC and homogeneous enhancements in T1 weighted contrast image. So ADC alone is not enough to differentiate primary CNS lymphoma from glioblastoma. Multimodal imaging techniques should be used in conjunction with ADC rather than ADC alone to diagnose the differential primary CNS lymphoma from GBM. Perfusion weighted imaging is another advanced imaging technique which is useful in diagnosing primary CNS lymphoma. Dynamic susceptible contrast, dynamic contrast enhanced arterial skin labeling are the usually used perfusion weighted techniques. Dynamic susceptible contrast is the most common technique used in perfusion weighted imaging, which can quantitatively give cerebral blood volume. The relative cerebral blood volume of the tumor lesions, which is calculated as ratio to the contralateral normal brain, is actually very low in primary CNS lymphoma compared to the glioblastoma. In a meta-analysis consisting of 14 studies, perfusion-weighted imaging had showed a high level of accuracy for differentiating high-grade glioma from primary CNS lymphoma. The differentiation between the primary CNS lymphoma and high-grade glioma is better on combining perfusion-weighted imaging and DWI. On combining relative cerebral blood volume and ADC, that is relative cerebral blood volume cutoff of 4 and a minimum ADC of less than or equal to 1 into 10 power minus 3 millimeter square per second, it can effectively differentiate primary CNS lymphoma from GBM. This is an image, T1 contrast weighted image showing heterogeneous lesion in the right paracentral region. Uh, this color coded CBV map. The corresponding lesion in the lesion over the lesion showing relatively low CBV, which is almost similar to the contralateral brain. So this patient actually had a very low related
Please talk into the mic.
had a very low
Yes.
had a very low maximum CBV, that is 1.33. A cutoff value of 1.75 is used to differentiate high-grade glioma from primary CNS lymphoma. Role of PET brain in primary CNS lymphoma. High homogeneous increase of FDG uptake is the typical metabolic pattern in primary CNS lymphoma. FDG uptake is measured by maximum standardized uptake value. Maximum standardized uptake value in primary CNS lymphoma is between 14 to 22. Cutoff value of 15 is being used to differentiate between primary CNS lymphoma and high-grade glioma. Uh, tumor tumor to normal gray matter ratio cutoff point of 2 is also used to differentiate primary CNS lymphoma from high grade glioma. Methionine PET is an amino acid PET, which is related to the amino turnover and the protein synthesis, related to the uh, high cellular proliferation. Methionine PET has certain advantages over the FDG PET, that the normal brain uptake of the methionine PET is slow. Hence, the delineation of the tumor boundaries of primary CNS lymphoma is better. So this is a case of primary CNS lymphoma, T1 weighted contrast imaging showing bilateral frontal hyperintensities, contrast intense focal contrast enhancing lesions. This is FDG PET image, and this is methionine PET image. The FDG PET image, there is no difference in uptake value between the normal gray matter and the tumor lesion. But in methionine PET, we are able to see that the uptake value is more in the over the tumor lesions than the normal gray matter. So these are the advanced imaging techniques in the CNS lymphoma. In DWI, we use the cutoff value of 1.1 of threshold ADC
Yeah.
to differentiate primary CNS lymphoma from malignant glioma or metastasis. In DTI, we have low fraction anisotropy, which can differentiate primary CNS lymphoma from malignant glioma or metastasis. In MRI perfusion imaging, we have a low maximum relative CBV, which will help in differentiating CNS lymphoma and malignant glioma. Cutoff value of 1.75 is used. In MRS, we find low NAA, elevated lipid peak, high choline creatinine ratio. This similar finding is seen in GBM also, but presence of lipid peak in the absence of necrosis points towards the CNS lymphoma rather than GBMs. Uh, the- The high choline creatine ratio is also used to differentiate the CNS lymphoma and toxoplasmosis in AIDS patients. Microhemorrhages and calcifications are rare in SW imaging in primary CNS lymphoma. These findings are usually seen in high-grade glioma. So,
Dr. Telangana, stay close to the mic, please.
SWA can differentiate primary CNS lymphoma and high-grade gliomas. PET scan, FDG PET scan and methionine PET shows hypermetabolic lesions with high uptake, which can differentiate CNS lymphoma from glioma and metastasis by using SUV max cutoff value of 15. So, yearly evaluation of therapeutic response is also possible by using the PET scan. SPECT imaging, N-isopropyl iodoamphetamine or thallium SPECT shows a hypermetabolic lesion with high uptake in primary CNS lymphoma. Uh, this can help in differentiating AIDS-related CNS lymphoma and infectious lesions. Several biological analytes like circulating tumor cells, self-refraction, circulating tumor DNA, circulating tumor RNA, protein, microRNAs, and other metabolites, extracellular vesicles are the components sampled in the liquid biopsy. These are the materials originating from the tumor cells and hence can represent the really represent the lymphoma source. The potential CSF these are the potential CSF biomarkers found in primary CNS lymphoma. Mutation of the cell-free circulating tumor DNA have found alterations in MID88 and CD79B. These mutations are very common, seen in about 40 to 80% of the cases. The cell-free circulating tumor DNA are even detected months before the detection by MRI or flow cytometry. Hence, can be used to detect the relapse very early. MicroRNA, like other biomarkers are microRNA 21, 19B, 92A, protein receptors, soluble interleukin 2R receptor, TACI, BCMA, proteins like osteopontin, neopterin, beta 2 microglobin, chemokine CXCL13, cytokine interleukin 10, 6, and 8 are the other potential diagnostic biomarkers. Um, Using this biomarkers for in the, presently in the clinical diagnosis is not recommended because the level of evidence is very low. Still, the stereotactic brain biopsy is the standard gold standard diagnostic approach. Treatment of primary CNS lymphoma, induction with high-dose methotrexate based regimen is a standard therapy for primary CNS lymphoma. Most of these regimens usually include temozolomide or rituximab. These are the few methotrexate-based regimens used in primary CNS lymphoma. Methotrexate plus cytarabine, methotrexate plus temozolomide, procarbazine and vincristine, vincristine and rituximab, temozolomide and rituximab, pharmastine, tiniposide, prednisone and rituximab, cytarabine, thiotepa and rituximab. Optimal consolidation therapy in treatment of primary CNS lymphoma is not well defined. But most, at least 50% of the patients after the induction therapy might relapse. So options include high dose chemotherapy with autologous stem cell transplantation or a non-myeloablative chemotherapy like cytarabine with etoposide, targeted agents like lenalidomide or ibrutinib, or reduced dose whole brain radiation therapy. In relapsed primary CNS lymphoma, retreatment with methotrexate is considered if there was a complete remission with methotrexate earlier. Alternative chemotherapy regimens include rituximab, high-dose cytarabine, lenalidomide, and high-dose chemotherapy with AST. Whole brain radiation therapy, stereotactic radiosurgery are also being done. There are few novel agents which are being studied in primary CNS lymphoma. Ibrutinib, the beta cell receptor signaling pathway is most commonly affected in primary CNS lymphoma. Ibrutinib binds to glucan tyrosine kinase and inhibits the B cell receptor signal transduction. Nivolumab is a monoclonal antibody blocks the programmed cell death receptor 1 and prevents T cells from being inactivated by programmed cell death receptor 1 ligand. Chimeric antigen receptor T cell therapy targeted against the CD19 is used in has been studied. Only phase 1 studies are available. Primary T cells are collected by apheresis, genetically engineered to express chimeric antigen receptors specific to patient's particular cancer. Cell is expanded in vitro and re-injected into the patient after lymphodepleting chemotherapy. Temisiran is a mTOR inhibitor. It is being studied. Phase 2 studies are available in relapsed or refractory primary CNS lymphoma. Though there was a radiological resolution in 50% of the cases, but progression-free survival was very low. These are the various sites where the novel therapeutic agents act. Uh, Beta cell signaling pathway is affected. This is the lymphoma cell. This is T cell. Beta cell signaling pathway and mTOR pathway and this PD1, L1 axis is being affected in lymphoma cell, resulting in lymphoma cell proliferation. So, ibrutinib blocks the glucan tyrosine kinase by and then results in blocking the B cell receptor signaling transduction. Temsirolimus acts as inhibitor of mTOR, and the nivolumab acts against the PD1, thereby inhibiting the inactivation of T cell. So, CAR-T anti-CD20 acts on the tumor-associated antigen, thereby resulting in killing of the lymphoma cell. So response assessment is being is provided by International Primary CNS Lymphoma Collaborative Group. Complete response is defined as no contrast enhancement in brain imaging with normal ophthalmological examination and negative CSF cytology. Partial response is defined as 50% increase in enhanced disease, decrease in vitreous cells or retinal infiltrates for suspicious CSF cytology. Progressive disease is defined as 25% increase in enhanced tumor with recurrent or new disease or any new site of the disease or recurrent or positive CSF cytology. Follow-up schedule provided by the International Primary CNS Lymphoma Collaborative Group is at year 1 to at completion of therapy every 3 months, at year 3 to 5 every 6 months, at between year 6 to 10 annually. Mandatory assessments at each follow-up include history, physical examination, cognitive evaluation, and gadolinium enhanced MRI. Optional assessment at each follow-up, if clinically indicated, include ophthalmological examination and CSF analysis. Treatment of secondary CNS lymphoma. High dose intravenous chemotherapy with methotrexate, which is used in primary CNS lymphoma, is also found to be efficacious in secondary CNS lymphoma. Intrathecal chemotherapy with methotrexate, cytarabine, and hydrocortisone reduces the systemic toxicity, and it is also found to be efficacious in secondary CNS lymphoma. Radiation therapy is only used when there is a failure of chemotherapy or a bulky lesion or the functional status of the patient prevents them from taking chemotherapy. The high dose chemotherapy with AST, autologous stem cell transformation, is at research level. Other experimental therapies which are used in which have been studied in primary CNS lymphoma like ibrutinib are still are being studied in secondary CNS lymphoma as well. CNS prophylaxis is needed in patients with in NHL in patients with aggressive or highly aggressive disease, high or a high intermediate risk disease by the International Prognostic Index, or a dual expression of the MIC or BCL2. Four or more of the following risk factors: like elevated LDH, serum albumin less than 3.5, or age more than 60 years, retroperitoneal lymph node involvement or extranodal site of more than one, lymphomatous involvement of the testis or orbit or breast, concurrent bone marrow involvement. Sinus prophylaxis, high dose methotrexate is used for the sinus prophylaxis also. So to conclude, multimodal imaging, including the advanced MRI imaging techniques and the PET scan, supports the reliable differentiation of the diagnosis of lymphoma from other malignant and non-malignant diseases. Biomarkers in CS from the CSF liquid biopsy is a relatively non-invasive diagnostic tool which is yet to be validated, and diagnostic value is yet to be confirmed. The whole brain radiotherapy, which is used in the consolidation phase in the primary CNS lymphoma, has resulted in severe neurotoxicity. Uh, so, autologous stem cell transplantation is being considered as an alternative. There are ongoing randomized trials comparing the autologous stem cell transplantation with the whole brain radiation therapy. Novel agents are promising in relapsed or refractory primary CNS lymphoma. Combination of novel agents targeting different pathways and counteracting the resistant mechanism is a key for future approaches. Thank you.
Dr. Lakshmi, please take
Thank you. Thank you, sir. Now uh, time is already almost up. So I request both the moderators and people to go to you can see the question and answers. You can answer a few of them, whichever you think it is relevant. You can choose and answer them. And I want you to take up the question and answers. You can click that, and then a few of them you can always reply by typing the answers also. Choose a few questions and complete the session. Professor Balasubramaniam and Professor Jawahar.
One attendee has asked whether why demyelinating etiology was not considered. The demyelinating etiology, patient having, initially responsive to steroids, but subsequently the patient having an unilateral ophthalmoparesis occurring only on the left side with proptosis. So that is quite unusual in a demyelinating etiology. Especially it indicates an structural lesion involving the retroorbital region because there was a proptosis. So that excludes a demyelinating etiology in this patient. That's why it is not considered. Was ISPAC test done? Is asked by Dr. K.M. Nazmul Islam Joy. So ISPAC test was initially done and it was negative, and so pyridostigmine was stopped. And all the neuromuscular junction investigations were done in this patient, all proved negative. So pyridostigmine, which was started outside, was stopped in this patient. Then why Lyme is not considered? Lyme was considered in this patient, but it's more the unilaterality in the cavernous sinus was quite unusual. Next is Dr. Prasanjit has asked, before the development of lumbosacral involvement, where would he have taken biopsy from? That was the dilemma in this patient right from the beginning, because he had only the cavernous sinus. We discussed with the neurosurgeons; they were hesitant to take the biopsy at the cavernous sinus. So, and patient was also not willing to take the risk. So, ultimately, only when the patient developed the lumbosacral region, the biopsy could be planned and taken. Now, how does one differentiate a cavernous sinus localization from a superior orbital fissure localization? Is proptosis present in a cavernous sinus disease? So already has been discussed by Professor Jawar that I think superior orbital fissure, the involvement will be more anterior, and here, it depends on the involvement of third, fourth, sixth. So superior orbital fissure, you can have involvement of third, fourth, sixth, and in a cavernous sinus localization, there will be involvement of V1, V2 also. V2 will also be present. That will more favor a cavernous sinus lesion, and obviously the presence proptosis can be present in a cavernous sinus disease because of venous congestion. Is optic nerve a must for supraorbital fissure? It is not a must. It usually occurs depending on the, if you know the structure of the supraorbital fissure, if the optic, the optic nerve, the orbital apex is involved, optic nerve is involved. Can you demonstrate fourth nerve examination, third nerve palsy has already been discussed by Professor Jawahar.
Actually, this is very simple. They already the involved eye, we should fix in a conjunctival vessel and ask the patient to look to the opposite side shoulder, so that you have to see for intorsion of the conjunctival vessel. If it is intorting, then definitely it is fourth nerve is intact. If it is not intorting, it is fourth nerve is absent. And one another person, they asked about what is the difference between IgG4, hyper IgG4 and sarcoidosis in MRI. IgG4, you will have a extraocular muscle swelling of the extraocular muscle, along with the tendons of the extraocular muscles also will get swollen. But in sarcoidosis, you won't get a swelling of the extraocular muscles. That is the one difference. But other findings are all one and the same. And one another person, they ask, why not consider CNS vasculitis? The CNS vasculitis, mainly the primary CNS vasculitis involving the parenchyma causing stroke-like symptoms. But usually in the lymphomatous, lymphoma associated with vasculitis and other sarcoidosis, all these things, they pick up peripheral nerves, the cranial nerves and peripheral nerves more commonly instead of parenchymalation. Parenchymalation can occur, but predominantly cranial nerves and peripheral nerves are picked up by the sarcoidosis and other this lymphoma with vasculitis and neurolymphomatosis and all. CNS vasculitis, in this condition, we will keep it on the last in the list. Okay. Thank you, sir.
I think most
Thank
of
you,
the
sir.
questions we have answered.
And if any of the questions left out, we will see that, and then we will reply by, and the reply shall be passed on by Mr. Arun Chadda. We will, any other questions left out, we just copy and send it to us. We will reply so that you can pass it to the concerned persons. With this, we come to the draw curtain to the first meeting of the secrets of neurology. First of all, I should thank our beloved Professor Sudhir Shah, Padma Shri recipient, and he is the backbone who initiated the whole idea. He gave me the idea. We just, under his guidance, we just collected whatever suggestions he said, we try to implement. And this is our maiden effort. But I actually, in such a short span of time, you get to know so many good points. I thank my colleagues, Professor Jawahar and Professor Balasubramaniam, who have put in efforts and their years so that the within the stipulated time, just 5 minutes late, but within the stipulated time, we could able to give the sufficient clinical material to the students. I thank Professor Assist, my good friend and Professor Telangana, who has made efforts for giving recent advances in update about primary and secondary CNS lymphomas. And not the least, Professor, our student, beloved student, Joby, who has made a good presentation. And my sincere thanks to Arun Chadda and the team, Heli, Shweta, and everybody were very prompt in communicating with us and getting everything done. And we shall be taking your second, sir. Anything?
Ravi.
Yeah.
Thank you.
My site coordinator is, but for him, the whole smooth organization could not have been done. And my hearty thanks to Dr. Ravi. And that entire team of the INTAS, the Celestial webinar, as they called it, we are very happy. And second thing is, I hand over to Professor Sudhir Shah to say that next month, last Friday, our venue, we're planning to move to the probably Mumbai, which Sir would confirm. And there are 5-6 great institutes are in the pipeline, as he Sir has said. So thanks for every of the participants And all your questions, whatever is there in the web, we will try to answer and reply to you by mail. Thank you. Thank you for all your. Thank you, sir. Over
Thank
to
you, sir.
Thank you.
Dr. Satish Khadilkar and his team has confirmed the next presentation that would be the last Friday of August. So thanks to Dr. Satish and his team from Bombay Hospital, Mumbai. And especially I must congratulate the student who really did marvelously well. And of course, Professor Bara Subramaniam, Professor Jawar, Professor Telangana for all your wonderful efforts and teaching. Thank you, Intas, once again. Thank you, Lakshmi, once again.
Thank you, sir. Thank you.
Thank you, sir.
Thank you,
Thank you.
sir.
Thank
Thank
you.
you. Thank you.
Good night.
Good night.
Good night.
Good night,
So, sir,
everybody. Thank you.
It's a thanks from the INTAS also. It's really great that we are at the end of the first session of Secrets of Neurology, turning out to be very successful. And I, Arun Chadha, Senior General Manager on behalf of INTAS Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable more than 450 delegates who blessed us with their presence. It's audience like you that make presentations awesome. Thank you very much for your unwavering attention throughout this presentation. It's a unique experience in which DM students, Dr. J.B. Thomas has presented the case in fantabulous way in length so that today's moderator, Dr. Balasubramanian, has explained it further very well. Dr. Jawar has taken his talk and Dr. Telangana has taken his talk very well. First of all, I would like to thank to Honorable Professor Dr. Sudhir Shah sir and Professor Lakshmi Narasimhan sir for designing such a wonderful series in which every time DM students will present their case and other professors of their institution will elaborate and discuss the case. I would like to thank Dr. Ravi, Dr. Joby Thomas, Dr. Balasubramaniam, Dr. Jawar, and Dr. Telangana for gracing today's event. And I'm very sure that our delegate must very much thrilled with the entire case studies and the question answer session. Once again, thank you for your gracious presence, and we will meet again on 31st August with the same time with another 2 interactive case studies in Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all of you, sir.
Thank you.
It would be 29th August. Yeah. 29th August, last Friday, yeah. And
Okay, sir.
thanks
Sir,
to the
28.
delegates. Thanks to all delegates once again. Yeah.
Thank you. Thank you very much,
Thank
sir.
you, sir. Thank you.
Thank you, sir. Thank you,
Thank you,
sir.
sir. Thank you.
Thank you, everyone. Thank you.
Okay.